Okay, Archana, can you stop, please? Good morning, everyone. It is 6:30. We will start our next lecture. Today is the last lecture of series 4, and this will be taken by one of our resident from KMC Manipal. And what I want to do, that I want to request Anuja Damani, the famous Anuja, committed, sincere. Everybody knows Anuja very well. So Anuja, may I request you to introduce the speaker or your resident, and then you can start. And anybody have any question, please write down in the chat box. We will take up, Anuja will take up at the end. And there are few announcements at the end, so please stay back till the end. Okay, Anuja, go ahead.
Okay, good morning all. Thank you, ma'am. Today we have a very important topic. Our speaker for today is Aswathi Praveen. She is a first year resident at KMC Manipal. And her dissertation topic is myofascial pains, and she has a special interest in myofascial pains and ICU palliative care. And Ashwathi is very committed and sincere, and I request Ashwathi to start with her presentation for today. In the meanwhile, while Ashwathi is trying to share her screen, let me introduce the topic. We come across a lot of patients in our clinic, and these patients don't come with one single morbidity. They will come with, these are cancer patients, or these may be patients with long-term illnesses, and these will come with special situations like renal failure, cardiac failure. They will be on many other drugs for their comorbidities. So we must know as palliative care physicians how to modify our symptom management medications according to the special situations that patients come across with. So Ashwathi, you can start now.
Thank you, ma'am. Good morning. I'm Dr. Aswathi Praveen, first year junior resident in Palliative Medicine and Supportive Care, KMC Manipal. My topic for today is palliative drugs in special situations. Overview of the presentation. I'll discuss it under the topics of palliative drugs in renal dysfunction, hepatic dysfunction, patients with cardiovascular morbidities, children, elderly, and cognitive impairment. Palliative drugs in renal dysfunction. Renal function. The best measure for renal function is glomerular filtration rate, which is calculated using the MTRD formula, which utilizes serum creatinine, age, sex, and ethnic origin. It is expressed as normalized value if the body surface area of the individual was 1.73 meters square. It is not appropriate for drug clearance and dose adjustment, misleading in situations of altered creatinine production, volume of distribution, and excretion rate. It is not validated in children less than 18 years, pregnancy, acute renal impairment, edema, malnourishment, muscle wasting, as well as amputees. In palliative care patients who are elderly, malnourished, or cachectic, renal impairment may exist even when the serum creatinine or eGFR value is normal. In individuals with a body surface area less than 1.73 meters square, the MDRD formula overestimates the renal function and may lead to drug overdosing. Stages of CKD. Depending on the eGFR value, the stages are divided into 5 different parts. If the eGFR value is more than 90, it is stage 1, where you have the normal renal function based on the urine finding as well as structural abnormalities. When eGFR is between 60 to 89, which is stage 2, it is mildly reduced renal function. eGFR between 30 to 50 is CKD stage 3, where you have moderately reduced renal function, and between 15 to 29 is stage 4, which is severely reduced, and less than 15 is stage 5, which is very severe, also the end-stage renal failure. Drug-related consequences of renal impairment. First, about the drug absorption. As the gastric pH increases, it results in increased gut wall edema, which reduces the per oral absorption of the drug. Drug distribution in the body is affected by various factors like edema and ascites, which leads to increased volume of distribution, in turn reduces the effect of water-soluble drugs. Cachexia or dehydration reduces the volume of distribution and increases the effect of drugs. Reduced albumin increases the unbound active form of the drug, which increases its effect as well as toxicity. Reduced tissue binding decreases the volume of distribution, which in turn increases the effect of drug. Coming to drug elimination, when there is a reduced GFR and tubular secretion, it results in reduced elimination of the active metabolites, thereby increasing the effect and toxicity of the drug. Pharmacodynamic changes. Uremia can alter the clinical response to certain drugs, which results in increased sensitivity to drugs acting on CNS, increased risk of hyperkalemia with potassium-sparing drugs, and increased risk of gastrointestinal bleed with NSAIDs. Dose adjustment. Drugs with minimal undesirable effects, we have to start low and monitor for efficacy and toxicity of the drug. Drugs with small safety margin, the dose depends on creatinine clearance, which is calculated using the Cockford-Gault formula, which is given as 140 minus age in years into weight in kilogram divided by serum creatinine in milligram per deciliter into 72. For females, it has to be multiplied by 0.85. Drugs where efficacy and toxicity are related to serum concentration, treatment is adjusted as per clinical response and serum concentration. Dose adjustment as per creatinine clearance as per Cockford-Gault formula, which is explained before. For monitoring drugs and renal impairment, evaluation of renal function within 2 weeks or when drug-induced nephrotoxicity is suspected. Opioids. In end-stage renal failure, there is reduced elimination. Thus, for all opioids, we have to start low and titrate as per response. In severe renal impairment, which in turn impacts the hepatic function, causing reduced hepatic clearance, reduced protein binding, and increased CNS levels and sensitivity. Drugs like fentanyl, buprenorphine, and methadone are highly protein bound. The opioids which are generally safe to use in end-stage renal failure are fentanyl, methadone, and buprenorphine. All three do not produce any active metabolites, and these drugs has to be started low and titrated according to the requirements. Fentanyl is used as a transdermal patch or continuous infusion, started at a lower rate of 12.5 to 25 microgram per hour infusion. Methadone, due to the unpredictable accumulation and risk of toxicity, even in absence of renal disease, it is started as 50% of the usual dose. Buprenorphine is given as either sublingual or subcutaneous at a low dose of 25 to 50% of the normal dose. We have to start with 5 microgram per hour dose. Cautious use of tramadol could be considered at a dose starting at 50 mg thrice daily or twice daily with maximum of 200 mg per day. They produce active metabolites and can have accumulation in end-stage renal failure also. Codeine and morphine are best avoided as they produce active metabolites and accumulates in end-stage renal failure. The maximum dose of codeine is 30 mg QID and morphine is 2.5 to 5 mg QID. Due to the lack of clinical trial data, tapentadol is not used in severe renal as well as hepatic impairment. Severe renal impairment as in creatinine clearance less than 30 and hepatic impairment as in child puke class C. In creatinine clearance more than 30 and child puke A, tapentadol requires no dose adjustments. In child puke B, 50 mg TDS could be given with a maximum dose of 150 mg per day. Antiemetics. All antiemetics used in palliative care can also be used in end-stage renal failure. Cyclizine, ondansetron, granisetron have no active metabolites or accumulation and renal impairment, so these can be used with unchanged dose. Risk of QT prolongation is seen with domperidone, haloperidol, and ondansetron. It is dose dependent. For domperidone, if it is given in more than 30 mg per day, there is risk of QT prolongation. Cautious use of domperidone and metoclopramide with maximum per oral dose of 10 mg twice daily and thrice daily respectively is used in renal dysfunction. They do not produce any active metabolites. Haloperidol, if used regularly, we have to reduce the dose to half of the normal dose. For occasional use of control of nausea vomiting, haloperidol can be used with dose unchanged, which is 0.5 to 1.5 mg per day. Adjuvant analgesics or drugs in palliative sedation. Valproate is highly protein bound, which in renal failure, there is reduced protein binding effect, which results in increased drug concentration, so it has to be started at a lower dose. Carbamazepine, clonazepam, phenobarbital, and phenytoin have longer half-life and toxicity become apparent after days or weeks. The first line drug which is used in end-stage renal failure as anti-epileptic is valproate. Carbamazepine and valproate, they do not have any active metabolites, so they can be used without any change in the dose. Cautious use of pregabalin as well as gabapentin in patients with renal dysfunction has to be ensured as it is renally excreted. The doses are adjusted in renal impairment as per the creatinine clearance, and supplementary single doses given after each dialysis. For pregabalin, creatinine clearance more than 60, starting dose of 75 mg twice daily with a maximum of 300 mg twice daily could be used. Creatinine clearance between 31 to 60, 25 mg TDS and maximum dose of 150 mg twice daily is considered. Creatinine clearance of 15 to 30, you can start pregabalin at a dose of 25 to 50 mg once daily with a maximum dose of 150 mg once daily. In less than 15, 25 mg OD followed by a maximum dose of 75 mg OD is used for pregabalin. In case of post-HD supplementary dose of pregabalin, when you're considering daily dose to be 25 mg, the supplementary dose can be 25 to 50 mg, which is usually given after 4 hours of hemodialysis. For 50 mg daily dose, supplementary dose of 50 to 75 mg is given, and for 75 mg, supplementary dose of 100 mg is given. For gabapentin, creatinine clearance, if it is between 50 to 79, starting dose of 300 mg HS and a maximum dose of 600 mg TDS could be considered. 30 to 49 ml per minute of creatinine clearance, the starting dose can be 300 mg HS and 300 mg TDS. For creatinine clearance between 15 to 29 as well as less than 15, 100 mg HS could be considered with a maximum of 300 mg BD if creatinine clearance is between 15 to 29, and if it is less than 15, 300 mg HS could be considered. In a study that was conducted for knowing the gabapentin and pregabalin use in association with adverse outcomes of hemodialysis patients, it concluded that the adverse outcomes like altered mental status, fall and fracture are higher in patients using pregabalin and gabapentin. So the judicious use of these agents in patients on hemodialysis has to be considered. Antidepressants. The first line of choice is sertraline. Citalopram is used cautiously as there is risk of QT prolongation and ventricular arrhythmia. Amitriptyline or nortriptyline are used in caution for neuropathic pain with lower starting doses. Avoid SNRIs like duloxetine and venlafaxine due to accumulation in renal impairment. Sertraline has no active metabolite, so it can be used as dose unchanged, which is 25 mg once daily. Cautious use of citalopram because there is active metabolites and it is a non-dialysable drug. Dose can also be unchanged, which is 10 mg once daily. Antipsychotics and benzodiazepines. The first-line antipsychotics considered in end-stage renal failure is olanzapine with a maximum dose of 5 mg per day. Haloperidol and quetiapine can be used cautiously. Haloperidol, we have to reduce the dose to half for chronic use, and quetiapine can be 25 mg per day. Avoid risperidone due to the longer half-life and unpredictable drug removal pattern. The first-line benzodiazepine, which can be considered as lorazepam at a dose of 500 microgram per day. Clonazepam can be used cautiously in restless leg syndrome. Diazepam is avoided due to accumulation of active metabolites. Miscellaneous drugs. Antidiarrheals like loperamide is used cautiously. It does not have any active metabolites or accumulation and renal impairment. Thus, the dose can be unchanged in end-stage renal failure. Bisphosphonates like zoledronic acid can be avoided if possible, as it is nephrotoxic and causes accumulation and renal impairment. Corticosteroids like dexamethasone, methylprednisolone, and prednisolone are safer and no dosage alterations are recommended. This is a table showing zoledronic acid dose adjustment in altered kidney function based on the creatinine clearance. If it is more than 60 ml per minute, 4 mg, the complete dose could be used. No dosage adjustment is necessary. 50 to 60 ml per minute, 3.5 milligram. 40 to 50 ml per minute of creatinine clearance, we can use about 3.3 milligram of zoledronic acid. And in 30 to 40 ml per minute, 3 milligram, and less than 30 ml per minute, the use is not recommended. Anticipatory prescription in end-stage renal failure patients at end of life. Fentanyl is preferred over morphine for pain due to the lack of active metabolites in fentanyl. In opioid naive patients, we can start at a lower dose, fentanyl of 12.5 to 25 micrograms subcutaneous. And if morphine is considered, it is used at a lower dose of 1.25 to 2.5 milligram. For breathlessness, along with the stronger opioids for breathlessness and pain, we can combine midazolam 2.5 milligram for concurrent anxiety. For nausea and vomiting, haloperidol is considered, which is 0.5 to 1 milligram, and we can consider infusion if the patient is requiring more than 3 doses per day. For agitation and restlessness, midazolam is preferred at an infusion rate of 5 to 10 milligram per day. And for delirium, haloperidol along with midazolam as the doses which is explained before can be considered. Palliative drugs in hepatic dysfunction. Prognostication. The commonly used model for prognostication is Child-Pugh classification for severe hepatic impairment. An important point is that although the predictive models are useful for predicting long-term outcome in end-stage liver disease and guiding treatment decision, they do not always align with patients' reported functional status and sense of well-being. Prognostic aid in cirrhosis indicate the degree of hepatic impairment. Child-Pugh score, it uses 5 different criteria, which is hepatic encephalopathy, ascites, bilirubin, albumin, prothrombin time, or international normalized ratio. And depending on the severity of these, it is given points as 1, 2, 3, and the final points of 5 to 6 is classified as class A, which is least severe liver disease. Class B is 7 to 9 points, moderately severe liver disease, and class C is 10 to 15 points, more severe liver disease. Pharmacological impact of hepatic impairment. In absorption, bile salts facilitates absorption of lipid-soluble drugs. Thus, in cholestasis, absorption is reduced, in turn, reduce plasma concentration and efficacy of the drug. In ascites or bowel edema, this also decreases the absorption of the drug. In conditions like cirrhosis and cardiac failure, there is reduced hepatic blood flow, which reduces the first-pass metabolism and increases bioavailability as well as half-life of the drug. Distribution and protein binding. In hypoalbuminemia and hyperbilirubinemia, increase free fraction of highly protein-bound drugs, which increases distribution and action of the drug. Water-soluble drugs like aminoglycosides distribute to ascitic fluid and has reduced systemic availability. Metabolism. Prodrugs like codeine and tramadol, which is metabolized by the liver to its active forms, and in severe hepatic impairment, this metabolization does not happen, so there is impairment in the efficacy of the prodrugs. Elimination. In cholestasis, clearance of drugs and metabolites with predominant biliary elimination will be impaired, like morphine. First-pass metabolism and peroral bioavailability. In cirrhosis, the development of portosystemic shunt lead to decrease in blood flow through the liver, and this reduces the first-pass metabolism of peroral drugs and increase bioavailability. Hepatic impairment and peroral bioavailability. Comparing the usual peroral availability and the effect of peroral bioavailability in hepatic impairment, those with high, which is more than 70% usual peroral bioavailability, does not have much effect in the bioavailability in hepatic impairment, as in the case of lorazepam. And the initial dose could be given as dose unchanged, and we have to reduce the maintenance dose. In those drugs like amitriptyline, haloperidol, and olanzapine, where there is moderate usual peroral bioavailability, which is about 40 to 70%, may increase in hepatic impairment. So the initial dose has to be low range of the normal, and reduced maintenance dose has to be considered. In domperidone, morphine, ondansetron, and sertraline, where there is low usual peroral bioavailability, which is less than 40%, can dramatically increase. So both the initial as well as maintenance dose has to be reduced. Red flag for dose reduction in hepatic impairment. Drugs which has low systemic peroral bioavailability due to the high first-pass metabolism, highly protein-bound with hypoalbuminemia and hyperbilirubinemia, drugs which has narrow therapeutic range and longer half-life. Other factors like severe cirrhosis, ascites, hepatic encephalopathy, hyponatremia, and renal impairment. Analgesics. Non-opioids. In severe impairment, reduced doses of peroral paracetamol is preferred over non-steroidal anti-inflammatory drugs. If unavoidable, ibuprofen is the choice among NSAIDs. NSAIDs have high risk of renal impairment, hepatotoxicity, and bleeding from varices. The pharmacokinetics of ibuprofen is not affected in hepatic impairment, but that of celecoxib affected in mild hepatic dysfunction. The dose of paracetamol is 500 mg thrice daily. Maximum dose of 1 gram thrice daily could be considered. NSAIDs are generally avoided, but in unavoidable situations, ibuprofen of maximum dose 200 mg thrice daily is considered. Morphine has a peroral bioavailability of about 35% normally, which increases to 100% in patients with severe hepatic impairment with cirrhosis. The plasma half-life also increases, which necessitates a decreased dose and frequency of administration of the immediate release products. In concurrent renal impairment, resulting in hepatorenal syndrome, morphine is avoided due to the accumulation of the active metabolite morphine 6-glucuronide, which leads to toxicity. Morphine can also result in spasm of the bile duct. Therefore, it is contraindicated in abdominal pain due to biliary colic. Fentanyl is a highly protein-bound drug and is exclusively metabolized by the liver. It has large volume of distribution and only small fraction is available for hepatic uptake. Thus, clearance is affected by changes in hepatic blood flow rather than reduced metabolism. Weak opioids are to be avoided, as in codeine and tramadol, which is activated by hepatic metabolism, causing decreased production and metabolism of active metabolite, leading to unpredictable effect. To summarize, all weak opioids are best avoided. Fentanyl, subcutaneous or continuous infusion, is the first line in severe hepatic impairment with concurrent renal impairment. Transdermal fentanyl can also be considered. Safer drugs in hepatic impairment is fentanyl, lower dose, which is 12.5 to 25 microgram per day, and infusion of 100 to 150 microgram per day is considered. Cautious use of buprenorphine sublingual with reduced dose of 25 to 50% of normal dose, and morphine peroral 5 milligram TDS or QID, and when it is given on an infusion, 10 milligram per day could be considered. Avoid codeine methadone as there is increase in half-life in severe hepatic impairment. Antiemetics. The antiemetic of choice is domperidone. All antiemetic agents used like domperidone, metoclopramide, ondansetron, and haloperidol have hepatic metabolism, and their half-life increases in hepatic impairment, resulting in reduced dosing of these agents. The maximum dose of domperidone and metoclopramide is 10 mg thrice daily, and that of ondansetron is 8 mg per day. Adjuvants, both pregabalin and gabapentin, these are not hepatically metabolized or excreted. They have low protein binding and short half-life. It requires slow titration to minimize sedative effects, and the dose is adjusted as per the concurrent renal dysfunction. Antidepressants. Among SSRI, citalopram is the best choice as it has less first-pass metabolism. SSRI decreased platelet aggregation, and there is increased risk of gastrointestinal bleeding and not used in coagulopathy or varices. The maximum dose is 10 mg OD per oral. Cautious use of mirtazapine can be considered. It has lower risk of bleeding, and it is avoided in hepatorenal syndrome, and it is more sedating. Dose is started as 15 mg HS, and maximum of 13 mg HS could be considered. Amitriptyline in neuropathic pain, contraindicated in cardiac dysfunction. Half-life doesn't increase in hepatic impairment. A dose of 5 to 10 mg per HS is usually given. SNRIs, like duloxetine and venlafaxine, they have significant hepatic metabolism, and there is increase in half-life in severe hepatic impairment, and preferably it is avoided. In unavoidable condition, a venlafaxine of 37.5 mg OD is the maximum dose which could be given. In a study conducted, which shows the hepatic safety profile of duloxetine, suggested that there is elevation of alanine aminotransferase to 3 times the upper limit of normal in about 0.9 to 1.7% of duloxetine-treated patients versus the placebo-treated patients. Hepatocellular and cholestatic hepatic injury were described in patients considered in the study. Antipsychotics. Long-term treatment with antipsychotics to be avoided in severe hepatic impairment. All three drugs has to be cautiously used, olanzapine, quetiapine, and risperidone, because all the three have hepatic metabolism. Quetiapine is the best choice for long-term treatment of psychosis, mania, and bipolar disorder, which is used at a dose of 12.5 milligram BD to start with. Benzodiazepines. It is used cautiously. Midazolam requires no dose adjustment. Lorazepam has active metabolite with hepatic metabolism started at a lower dose of 500 microgram per day. Zopiclone again has active metabolite and the half-life increases to more than 100%. We have to start very low at 3.75 milligram HS. Avoid, if possible, are clonazepam as well as diazepam, which has long half-life and time taken to reach steady state, and undesirable effects become apparent after several days of regular use. Miscellaneous drugs. Antidiarrheals. Loperamide has significant hepatic metabolism and is advised to avoid, if unavoidable, 2 milligram stat dose is considered. Bisphosphonates and laxatives are safer as they do not have hepatic metabolism, so can be used as dose unchanged. Dexamethasone have significant hepatic metabolism and increase in T-half in severe hepatic impairment, leading to cautious use. To start with, 2 to 16 milligram once daily dose could be considered. Palliative drugs in patients with cardiovascular morbidity. Analgesics. NSAIDs are better avoided in patients with cardiovascular morbidity. They trigger heart failure by causing sodium and water retention, increases systemic vascular resistance, and has blunted response to diuretics. In a study conducted to know the association of non-steroidal anti-inflammatory drugs with first occurrence of heart failure and with relapsing heart failure, in about 7,277 long-term NSAID users over 72 months, concluded that the use of NSAID is not associated with increased risk of incident heart failure. In patients with prevalent heart failure, current NSAID use is associated with substantially increased risk of relapse. All NSAIDs increases the cardiovascular risk in patients who are hypertensive with history of previous myocardial infarction or those who had history of recent heart surgery. So effects of NSAID in hypertension and heart failure. Except aspirin, all others have potential to raise the blood pressure and exacerbate the existing hypertension. Celecoxib and naproxen have lower risk than ibuprofen. In an observational study, over 40,000 patients who had history of heart failure with subsequent use of non-steroidal anti-inflammatory drugs reported a dose-dependent increase in risk of death, which was highest with diclofenac. Higher doses of ibuprofen, which is more than 1000 milligram per day, and naproxen more than 500 milligram per day, were also associated with increased risk of death. Major cardiac events like myocardial infarction are also associated with dose-dependent use of non-steroidal anti-inflammatory drugs. A systematic review on the risk of heart failure and edema associated with use of pregabalin concluded that the use of pregabalin resulted in increased risk of peripheral edema and exacerbation of heart failure. Tricyclic antidepressants, they have the potential to cause sinus tachycardia and postural hypotension, and further causes QT prolongation resulting in second or third degree heart block. SSRIs have lower risk in cardiovascular morbidity. In a study conducted showing the cardiovascular effects of fluoxetine in patients with heart disease, concluded that there was fluoxetine induced a statistically significant 6% decrease in heart rate, 2% increase in systolic pressure, and 7% increase in ejection fraction. And there was no effect on cardiac conduction, ventricular arrhythmia, or orthostatic blood pressure. Overall, 4% of fluoxetine patients had an adverse cardiovascular event. In contrast to nortriptyline treatment, where there is significant increase in heart rate, orthostatic hypotension, and 20% of nortriptyline treated patients had an adverse cardiovascular effect. Drugs discontinued in end of life. Antiarrhythmic agents, which lowers the blood pressure and contributes to fatigue, but can be considered in symptomatic tachycardia. Amiodarone, which have a longer half-life, about 6 months, can be stopped at the end stage. Anti-anginal are discontinued in absence of angina. However, lower dose of isosorbide mononitrate may help in breathlessness. Statins and antihypertensive agents could be discontinued at end of life as there is no symptom relieving properties. Palliative drugs in children. In children, consider for non-drug options, prescribe only for definitive indication. Simplify regimens. Avoid administering drugs at school or while the child is asleep. Dose calculations are done based on weight. Special care while prescribing for neonates because of the immature renal as well as liver function. and the immature reticular activating system, there is higher volume of distribution in them. In neonates, there is lower renal and hepatic clearances, therefore causing higher volumes of distribution results in longer half-life of the drugs. So we can administer lower doses of drugs at longer intervals. Neonates have less fat and muscle, which results in increased bioavailability of the drug. There is higher risk of respiratory depression with opioids in them. In infants and children, there is relatively high drug clearances and normal volume of distribution, and the drugs will have a shorter half-life and higher doses are administered at shorter intervals. Drug dosing depends on the physiological characteristic of child and pharmacokinetics of the drug. It depends on body weight, surface area and composition, organ maturation, impact of the disease at different stages, and route of administration and drug interactions. Non-opioids, WHO recommends the use of paracetamol and ibuprofen in children. Paracetamol in 0 to 29-day-old baby, 5 to 10 milligram per kg every 6 to 8 hours is considered. In 30 days to 3 months, 10 milligram per kg every 4 to 6 hours. 3 months to 12 years, 10 to 15 milligram per kg every 4 to 6 hours is the dose. So maximum is 4 doses per day. For ibuprofen, it is considered in children of 3 months to 12 years as 5 to 10 milligram per kg every 6 to 8 hours with a maximum dose of 40 milligram per kg per day. Opioids in 1 month to 1 year, morphine. Oral morphine is about 80 to 200 microgram per kg every 4 hours. When morphine is used as IV in 1 to 6 months, 100 microgram per kg every 6 hours, and in 6 to 12 months, 100 microgram per kg every 4 hours is considered with a maximum of 2.5 milligram per dose. As IV infusion, 1 to 6 months, 50 microgram per kg followed by 10 to 30 microgram per kg per hour. In 6 to 12 months of children, 100 to 200 microgram per kg followed by 20 to 30 microgram per kg per hour. Fentanyl, when it is given as IV, 1 to 2 microgram per kg every 2 to 4 hours is considered, and in infusion, initial 1 to 2 microgram per kg followed by 0.5 to microgram per kg per hour. In 1 to 12 years, when oral morphine is considered, in 1 to 2 years, 200 to 400 microgram per kg every 4 hours, and in 2 to 12 years, 200 to 500 microgram per kg every 4 hours with a maximum dose of 5 milligram. As IV, 100 to 200 microgram per kg every 4 hours with a maximum dose of 2.5 milligram per day is considered. As IV infusion, initial dose of 100 to 200 microgram per kg followed by 20 to 30 microgram per kg per hour is the dose of morphine. Fentanyl IV 1 to 2 microgram per kg repeated every 30 to 60 minutes. Metabolism of codeine in children. Codeine is metabolized mainly by conjugation to codeine 6-glucuronide, which contribute to its analgesic effect. Most of the analgesic property arises from the codeine, which is converted to morphine by O-demethylation by CYP2D6 enzyme. If this pathway is blocked, codeine lacks significant analgesic activity. So in CYP2D6 ultra-rapid metabolizers, there will be toxicity due to morphine resulting in respiratory depression. Poor metabolizers produce little or no morphine and obtain little or no pain relief from codeine. It is usually contraindicated in children less than 12 years of age. It is used in children more than 12 years with maximum daily dose of less than or equal to 250 milligram per day in divided doses with a duration of less than 3 days. Stronger opioids like fentanyl, morphine, which is used safely in children to relieve breakthrough pain. Fentanyl and buprenorphine transdermal patches used as long-acting opioid formulations for children. Common adverse effects are pruritus and urinary retention in children. Antiemetics, chance of age-related increased risk of dystonic reaction with D2 antagonists like metoclopramide. So it is used in caution in less than 20 years and never used in infants. Domperidone used with caution due to undesirable cardiac effects, and there is limited evidence of efficacy, so it is used in lowest dose and shortest time. Corticosteroids, the most common reason in pediatric palliative care is headache and vomiting due to raised intracranial tension associated with intracranial tumor. Children have rapid onset of Cushingoid phases, proximal myopathy, weight gain, and changes in mood and behavior. Short course is usually given of dexamethasone less than 500 microgram per kg per day for 3 to 5 days for raised intracranial tension. In case of continuous dosing needed, it is done at lowest effective dose and shortest time due to increased undesirable effects and increased difficulty in weaning off corticosteroids. Palliative drugs in elderly and cognitively impaired. Elderly, usually more than 65 years, receive multiple drugs for existing comorbid conditions, increases chances of drug interactions and adverse reactions. There is increased difficulty in swallowing tablets, so we can instruct to take tablets or capsules with fluids in upright position to minimize chances of aspiration. Alternative like liquid formulations and routes of administration may be preferred. Risk in prescribing elderly. There is risks of postural hypotension, sedation, delirium, and falls on prescribing antidepressants in elderly, urinary retention and constipation as a result of antimuscarinics. Hypnotics may result in cognitive impairment and delirium, and NSAIDs have increased risk of GI bleeding and fluid retention. Reduction in lean body mass and increase in body fat will alter distribution of lipophilic drugs like benzodiazepines and fentanyl. When given initially, it will be stored in body fat, reducing the initial effect, but repeated administration may lead to prolonged release and significant increase in drug plasma concentration. Cognitive impairment like idiopathic Parkinson's disease, metoclopramide and haloperidol, which are D2 antagonists, has to be avoided in idiopathic Parkinson's disease because it exacerbates rigidity and bradykinesia. Antiemetics least likely to exacerbate idiopathic Parkinson's disease are domperidone because it has negligible blood-brain penetration and it has lesser extrapyramidal symptoms. Antiemetic of choice in nausea related to anti-Parkinsonism dopamimetics. Ondansetron can also be considered in idiopathic Parkinson's disease as antiemetic. A study which was conducted which is a 7-year prospective study to investigate the effect of non-steroidal anti-inflammatory drugs on cognitive function of elderly patients who are older than 65 years, found no significant association with either dementia or cognitive decline incidence. NSAID should be prescribed in lowest effective dose with careful surveillance to monitor the gastrointestinal, renal, and cardiovascular toxicity in elderly. The risk and benefits to be balanced to optimize overall outcomes in the individual patients. Quetiapine is an atypical antipsychotic which has the least likely for extrapyramidal movement disorders used in delirium or agitation in Parkinson's. A study which was conducted to identify the quetiapine safety in older adults, which is a systematic literature review, suggested that compared with risperidone and olanzapine, quetiapine had significant lower risk of mortality, reduced rate of cerebrovascular events, and increased rate of falls and injury, and less metabolic disorders compared with olanzapine, but higher metabolic disorders compared with risperidone. Benzodiazepines have tendency to exacerbate delirium features. If unavoidable, can be used as midazolam 2.5 mg or lorazepam 0.5 to 1 mg. To summarize, it is essential to adjust the dosage of drugs in special situations like renal and hepatic impairment, cardiovascular morbidity in children as well as elderly to prevent toxicity as well as further damage to the system. It is equally important to achieve the symptom control in such populations. Thus, the drugs could be adjusted in such a way that patients are benefited with symptom control and no further damage could occur in system, keeping in mind that all the drugs has to be started low and we have to go slow and we have to titrate slowly. Thank you.
Anuja? Yeah, go ahead,
thank
please.
you, Aswathi. You've nicely summarized the use of commonly used drugs for symptom management in our setup in palliative care setting with dose adjustments with renal failure, liver failure, which has more evidence as compared to other comorbidities. But you've also summarized about the adjustment in neonates, elderlies, and patients with cognitive decline, cardiac failure. So these patients are commonly coming to our OPDs. We'll take a question from chat box. I think Dr. Rajesh Mahajan has asked question about why bioavailability of morphine is increased in hepatic dysfunction, and about zoledronic acid in multiple myeloma, how to titrate and precautions. So coming to first question from Dr. Mahajan, why bioavailability is increased. Aswathi, would you like to take it or I should go ahead and take the question?
Ma'am, you can go ahead, ma'am.
Okay, so Ashwati has already explained in her presentation that what happens physiologically in liver failure. So when we look at liver failure, there is increase in portosystemic shunting and increase in collateral circulation. Usually, what is bioavailability? When these drugs undergo fast metabolism from liver and then enter into systemic circulation. But due to portosystemic shunting, normally the bioavailability of all the drugs would increase in liver failure. So I would ask you to refer to some articles which describe the physiological changes in liver failure, and you will know why the bioavailability increases. It is not only for morphine, but in general for all the drugs which are perorally given, the bioavailability will increase. So all the analgesics you should use carefully in liver failure. Coming to
Anuja, can I answer that?
sure.
Yeah. So, Dr. Rajesh, morphine undergoes glucuronidation in the liver. So the glucuronidation, it converts into M3G, that is morphine 3 glucuronide and morphine 6 glucuronide. So this is the how the morphine becomes a metabolite in the liver. So whenever this hepatic impairment is there, the glucuronidation process gets impaired in the liver. So once the glucuronidation process gets impaired, the morphine, the action is because of its metabolites. Okay, so especially the M3G. So because of the impaired glucuronidation, the bioavailability of the morphine suddenly goes up, and more morphine is available for action, and the metabolites are not available. So that's why the bioavailability changes with the hepatic impairment. And in renal failure, what happens is these metabolites accumulate. So both active morphine and the metabolites, both of them are present. So in presence of hepatic impairment, morphine does not get converted into metabolites, whereas in renal impairment, the metabolites which are formed gets accumulated. So that's why in both renal and hepatic impairment, it is we have to be very cautiously using it. Thank you.
Excuse me, sir. I have a question.
Yes, sir.
Excuse me. This means that efficacy of morphine would be decreased in hepatic failure.
No, it's not.
Because
It's
it
not.
is not going converted to active metabolites.
No. Efficacy, both morphine in its active form and its metabolite form are active. Okay.
They are equally effective, you mean to say?
Yeah,
sir?
no. The metabolite form are more effective.
So that
Okay.
means efficacy should decrease in the hepatic failure.
No, it won't decrease because the significant, see, once the metabolites are formed, it gets immediately cleared by the kidney. Remember that. So you have a lot of active morphine available for action. Whereas when the metabolites are formed, they're immediately cleared by the kidney. Okay. Although metabolites are more powerful than the active morphine, they're immediately cleared. So it's not available for action in normal case. Okay. So in hepatic impairment, the morphine toxicity risk is much more because even though metabolites are more stronger, these metabolites are not available in a normal functioning kidney.
Yes.
Okay.
Thank you.
Dr. Rajesh have also posted one article on the chat. If you can refer to that article, you'll also see a lot of reference about why bioavailability of medications is more in liver failure. So, so one of the explanations, as sir said, about accumulation of morphine and accumulation of the not undergoing glucuronidation in liver is one of the explanations, and as well as increase in portosystemic function is another explanation of any other analgesics getting higher bioavailability, peroral bioavailability in liver failure. Now, coming to your second question about zoledronate in multiple myeloma. So, zoledronate doesn't require any dose adjustment in liver failure. In renal failure, I think Ashwati has already mentioned how do we dose adjust zoledronate. So, it can be used, but with dose adjustment in renal failure. But there is no dose adjustment required in liver failure for this particular drug.
Yeah, I
Now,
wanted to just ask, should we use or not use? Because our oncologists say that kidney is already predisposed. Even if creatinine clearance is normal, you avoid the zoledronic acid. What should we do?
yeah,
Even
so
if
That,
creatinine clearance.
dose adjustment can be done as per the renal failure. So you should not use it if it is end stage renal disease, but dose adjusted zoledronate can be given if patient has creat clearance less than 60, but more than more than 30. So you can use zoledronate, but with caution.
only
But
if it's less than 30 is contraindicated.
yeah.
Otherwise, you can use it safe.
Sir, but
And
how do
one
you
more thing
balance this
is you can
nephrotoxic effect?
use denosumab as an alternative, because denosumab will not require dose adjustment.
It
But
is possible.
the only problem with denosumab is cost of denosumab is pretty high as compared to zoledronate.
Yes,
So
yes.
zoledronate can be used with caution, with dose adjustment as per what chart Dr. Aswathi has mentioned. It's there online reference as well. You can refer to it online. But over 60 creat clearance, you can use zoledronate
Yeah, I just
even in
wanted to know
myeloma patients. Yeah.
how do you balance its nephrotoxic effect and creatinine? Both have to be balanced. Because
Zoledronate,
Zoledronic has no
yeah,
nephrotoxicity.
it is not nephrotoxic drug, sir.
No.
It is
Okay,
not
okay.
a nephrotoxic drug like NSAIDs. It is not
Okay.
like non-steroidals, which will affect kidney function, but it gets
Okay.
accumulated in kidney failure. Even for morphine per se, morphine is not a nephrotoxic drug. It accumulates, the metabolites accumulate
Okay.
in
Okay.
kidney failure. So zoledronate is not a nephrotoxic drug. It will not add to the nephrotoxicity or renal damage, but it will not get cleared in renal damage. So we do dose adjustment of zoledronate. I
Okay.
think
Thank
that should
Thank
answer
you.
this question.
Thank you.
So coming to our next question, what are the pain medications used in pregnancy? Can opioids be started in severe pain in any of the trimesters? So we have had experience with pregnancy patients and managing pain in pregnancy. Opioids can be given, but with caution. We should avoid using opioid in third trimester, because definitely opioids are not safer choice. So better to avoid opioids as far as possible in pregnancy. Even NSAIDs are not safer in pregnancy. So we can use paracetamol, and if patient does not have pain relief with paracetamol, I think the opioid which is safest I would suggest is buprenorphine. Even fentanyl can be used, but very much with caution. First trimester, it's okay to use. Second trimester as well, but third trimester, we should be cautious, because when these patients have, we give opioids during perinatal period, the child or the neonate might have withdrawal symptoms while childbirth. So we should be cautious, and of course we should deal with pregnancy in collaboration with our colleagues from gynecology and obstetrics, so that they can also have their inputs on how do we dose adjust opioids in pregnancy. Naveen sir, would you like to add to this?
No, I agree with whatever you said. That's what we have been following for all the pregnant women. That's what we are seeing.
Sushma madam, would you like to add anything to this?
Yes, it
Use of
is
analgesics
important that in pregnancy, in liver disease, and in kidney disease, all these, they are important organs. It will morphine and all these metabolize through liver and excreted through kidney. So we have to be very cautious. And in pregnancy, definitely we have to be very, very cautious, because it is going to be affecting the kid, the child, uh, rather neonate, rather than the lady. So if most of the time in 2 or 3 circumstances, what we have done early, because it is not necessary to go till 36 weeks of pregnancy. So with the, as Anuja said, that with in the collaboration with obstetrician, if it is very, very important to give morphine or fentanyl and patient is in severe pain, I think little early giving birth to the child and giving pain relief to the mother, I think we have to balance and we have to coordinate with obstetrician very well to give pain relief. And buprenorphine is again a choice, but again I will try to not to give opioids and deliver the baby first, healthy baby if possible, and then give opioids. I think this will be a better choice rather than coordination with obstetrician is very, very important. Thank you, Anuja. This was a very important point. Go ahead.
Yeah. We'll go to the next question. What are pain medications? Okay, you've answered this. Next question is about tramadol. This is from Pain and Palliation. Okay, between tramadol and morphine, we prefer a very low dose of morphine as tramadol lowers seizure threshold. So I don't know what the question is here, but definitely tramadol lowers seizure threshold at higher doses. So we should be cautious.
I am happy to. Yeah.
Yes, sir. Please go ahead.
That's not as straightforward as it is. It's not a blanket rule that tramadol lowers seizure threshold. Okay. We need to go more deeper into that. The tramadol has two metabolites. One is O-desmethyl tramadol and N-desmethyl tramadol. So there's O-desmethyl tramadol and N-desmethyl tramadol. Both goes to the CYP pathway, but the O-desmethyl tramadol comes through the CYP2D6 pathway, and N-desmethyl tramadol comes to CYP2B6 and CYP3A4 pathway. Now, only in those people who are ultra metabolizers of CYP2D6, because O-desmethyl tramadol, which is the active metabolite of tramadol, is 200 times as potent as tramadol. Now, only them, this population, are at risk of seizure. Okay. Now, who are those who are ultra rapid metabolizers of CYP2D6? We won't know unless you do a genotype and phenotype for them. So it is not a very blanket rule, but to be on the safer side, we could do that. We could, but this is the thing. So that's why whenever we are using tramadol, we have to be cautious because we don't know the genotypes of them.
Yes, Naveen,
Absolutely, Naveen. I think we should refer the lecture on tramadol. I still remember that everything has been explained very well while taking tramadol lecture. So go to the IAPC website, search for tramadol lectures, and everything, all the answers you will find in the tramadol lecture. Okay, go ahead, Anuja.
Sushma, that question was from me. I'm Shobha here. Sorry, it's shown as pain and palliative. So, in tramadol and morphine, most of our patients are on Levipil and metastatic brain metastasis with Levipil with prevention of seizures. Already they've had seizures and things like that. So in those kind of patients, we use we have buprenorphine oral, so we prefer that. But in case we can't use it, then we use a very, very low dose of morphine, especially in these patients. And although it is not recommended, it can be given in a very small dose. So that's why I put that point across. Thank you.
Okay, Anuja, next question, please. Go ahead.
Yes. I think we have that many questions. One point that Dr. Pankaj has also made is that zoledronate, when we give in renal failure, we should give it with a lot of hydration, and that is correct. Absolutely, that we should give it with hydration along with because if we don't give it with hydration, again there is chances that it may cause further renal damage and exacerbate renal failure. So that is one important point that Dr. Pankaj has also made, which I agree with, and I think people should know about it. Whenever we use drugs like zoledronate, any drug in renal failure which tends to accumulate, we should give it with hydration in renal failure. Okay, so ma'am, I think we don't have any further questions in this chat. And congratulations, Aswathi, you've really given a very brief and very nice presentation about such an extensive topic. Ma'am, go ahead with the announcements that you had.
So, Anuja, thank you very much. Thank you, Aswathi. Thank you, Naveen.
Thank you,
Shobha,
ma'am.
for giving your excellent input, Naveen, and Shobha giving for your comments. Now we will just have an announcement. Today is World Patient Safety Day, so IAPC organizing one webinar from 5 to 6:30. Archana will send the details of link and everything on various platforms. Please join as many people as possible. 5 to 6:30.
Ma'am, it's
Yeah.
not today, ma'am. It's on 17th September, ma'am.
Okay,
We're on-
17th. Sorry, 17th September today. Okay, 17th September. Sorry. So second thing, I have told you that IAPC is going to give 10 best abstracts the award. So please send your abstracts as many people as possible. Only one condition that you should be IAPC member, and then you will get this award if your abstract is best abstract. So please join as many people as possible. Please send your abstract so that conference visibility will improve and you will get the award. Third thing, was the last lecture of the series 4. This again, I want to thank Naveen for helping in all these topics and speakers and everything. So series 4 is over, and again the very well planned series 5 will start, which again was formulated and conceptualized and planned with the help of Naveen. That is going to be very, very important for all the youngsters and juniors, those who want to really work in the research area. So please don't miss these classes, because these classes will be all from the very, very senior people, right from how to write a protocol, and then how to write a systematic review, how to search for literature, and then how to write papers, and all these things, all important thing which we really miss in our day-to-day practice is going to be there. So please join from next Monday onwards. All these classes are important and will be taken by very, very senior people. Don't miss, because these chances, you will not get this chance. These are important and very, you are fortunate that all these classes are happening and you should join. So before this, any other announcements, Archana? I don't think right now.
No, ma'am.
Okay, so thank you very much. Thank you everyone for joining early in the morning, and thank you Anuja and Ashwini for such a brilliant presentation. And I think it is very, very important that we should know which drug should be given and what is the dose which should be given in various conditions. Go to the lecture, because it will be difficult to remember. And as we said that we will make a very good draft, and we will post in the IAPC maybe in the next week, that what are the drugs, what are the doses, and where we should be very, very cautious. So thank you Naveen, and thank you very much, and please join next week before 6:30 next Monday. Have a nice week. Thank you.
Ma'am, next
Thank you.
lecture is on 22nd August. There's a 1-week break, ma'am. Series 5
Okay,
starts.
so
from
it is
20
again a very important announcement, otherwise everybody will search for this. So 1-week break, and then we will join on 22nd August. Thank you Archana, it was a very important point. Okay, thank you Archana
Thank
and
you,
Nisha for keeping me on track and keeping everybody on track. Thanks a lot.
Thank you, ma'am.
Thank you,
Thank you.
Naveen.
Bye.